what about the research? We talked about diaphragm motion. This study looked at diaphragm motion in healthy subjects. There are 174 healthy volunteers. They looked at both diaphragm. You can look at the diaphragm by their movement. You can tag it with the dots here or put a lines here. What they found was average excursion of the diaphragm and peak motion speed measured was higher on the left side in the healthy normal population. And if the patient has a large BMI or their vital capacity is higher, they are associated with higher excursion and faster speed, which you can plot them in these diagrams. Looking at the right hemidiaphragm is red and blue is the left hemidiaphragm, both higher excursion and higher speed. This is healthy population. What about in COPD? This group looked at small group of patients in COPD. What they found was that COPD patients during tidal breathing, regular breathing, their diaphragm excursion is higher as compared to healthier. And left is still move more than right. But when you tell them to forcefully do the breathing, their excursion and speed of motion is decreased. Not with tidal, but with forceful. So what is the clinical implication? Clinical implication is larger diaphragmatic motion occurs during resting to compensate for hypoxia due to less gas ventilation exchange in the rest of the COPD lung. And that leads to, because the diaphragm is working more, it leads to respiratory fatigue during day-to-day life. And if you tell these patients to walk a little bit or do some exercise, they get worse because now their diaphragms are not even moving that much, so they get short of breath very quickly. So this is an objective way of looking at why the COPD symptoms are occurring in these patients. We can also look at air trapping in COPD patients. This is a paper which looked at 118 patients with airflow limitations. They looked at the relationship between the lung area and the rate of change of lung during the maximal inspiration and maximal expiration. What they found out, the rate of change of lung area from maximum inspiration to maximum expiration, which is RS ratio, it was associated with RV over total lung capacity ratio in COPD patients, and it corresponds to the decrease in FEV1 level, which are seen in COPD as the air trapping is severe. So in severe air trapping, which is here, the RS ratio correspondingly decreased much more. So you have some kind of correlation for suggesting significant air trapping by these parameters comparing with the pulmonary function test. What about effect of treatment, bronchodilator? Here is the 53-year-old with the COPD. Before treatment, you can look at the lung areas, and after 3 months of bronchodilator, clearly the lung areas are better. They are expanding better. They are more increased expiration, so less residual volume, and you can plot them showing before treatment and after treatment. I think this is a very good modality to look at effectiveness of any treatment for asthma or any condition where you are trying to give bronchodilator and look at the effect. What about the VQ research? Again, this is very basic stuff. There are only few reports out there. This patient has a chronic pulmonary thromboembolism, okay? And these images are pre-thromboendarterectomy, and you can see a large filling defect on perfusion scintigraphy, what we do traditionally here, and there's a perfusion defect in the left lung. Similarly, on the DDR, you can see that the color is low as compared to this, as well as here. Okay, and on angiography, because some institute, they still do pulmonary angiography before doing endarterectomy, you can look at decreased vascularity of the entire right lower lobe as well as left upper lobe part of it. So after thromboendarterectomy, we can see the basal portion, which was not perfusive well, is now perfusing well on both sides, although left side is not, but right side definitely moved. But the perfusion on the upper lobe is actually decreased. This is basically a compensatory decreased flow because now blood is going predominantly to the lower lobes. And it corresponds with the DDR images as well as with the catheter angiography. So I think this may have a role in future remember, this is just from a chest radiograph. You can get all this information. This is a very fascinating case. Ventilation-perfusion of a patient, 74-year-old with exertional dyspnea. If you just look at the radiograph, we don't have the radiograph, there was diffuse oligemia of the left lung, which can be subtle to detect, especially if you're not used to looking at the chest radiograph. But looking at these images of the vasculature or blood flow, you can see there is total absence of blood flow in the left lung. So traditionally, this will indicate that this is due to vascular occlusion. Commonly will be thrombus or embolus. It is not ventilation problem because there is no evidence of lung atelectasis. Lungs are perfusing well, or ventilation is good. In this case, it turned out this patient has a joint soil arteritis, and there was an aneurysmal dilatation and occlusion of the left lung pulmonary artery. So, a great case for demonstration. Probably has some utility. I'm not saying, you start doing, in suspected vasculitis DDR. No, but once this technique gets mature, we start looking at what can be the false positive or negative results with this technique. Once it gets mature, I think it has a lot of potential. Again, by looking at only DDR, radiograph, low cost, low exposure, you can get actually a bigger picture. Once you have this, you can target your further evaluation with limited cross-sectional imaging. So of course, you have a lot of other, you can play with these, all kind of joint. Again, a lot of potential in post-treatment or looking at the joints. Well, it's not going to show you. I didn't do it. It automatically switched over next. But there is a lot of potential for bones too. So DDR images provide more visibility by clearing the anatomy. It can quantify the motion of the diaphragm, and it can also provide some functional evaluation of the ventilation as well as perfusion. So in conclusion, we improve the visibility of the lung abnormality that make our confidence more accurate. It can provide evaluation of the diaphragm very well. We are going to replace with conventional fluoroscopy. The potential of functional data correlation with pulmonary function tests, I think it is huge in COPD, whether it's asthma or chronic bronchitis or emphysema. It can also have a potential useful in pandemic area where you cannot do PFTs, but you can get a broader picture of pulmonary function from DDR. Advanced computer analysis for ventilation and perfusions, once they are mature, they can be very useful. As I said before, currently workflow issue is there because it takes more time to process those images after the radiograph is done. And I am told that with the more, just like a computer, these are new computer comes with a faster processing time, speed, and this time will be decreased with the newer versions. And I think that will help decreasing the negative impact on the busy practice.